Assalamu alaikum wa rahmatullahi wa barakatuh. This is Dr. Noha Hatun, Obsingani at Rostaq Polyclinic. Our lecture today is about infertility management in primary healthcare. So first of all, we have to know what is mean by infertility. Infertility is inability to conceive after 1 year of unprotected intercourse. This is if she is younger than 35. If the patient is 35 and above, it is 6 months. Primary means she has never been able to conceive. Secondary have been able to conceive at least one, whether miscarriage or preterm or full term or cesarean. And the study found that by the end of 1 year, 90% of normal couple will have conceived. After 3 years, 99% of normal couple will have conceived. Incidence in general, it is 10 to 15% of all married people. So, evaluation should be immediately in the following condition. First, if the woman is 40 years and above, if she has history of oligomenorrhea or amenorrhea, history of chemotherapy, radiotherapy, advanced stage endometriosis, women with none or suspected uterine or tubal disease, male with history of groin or testicular surgery, impotence or other sexual dysfunction, chemotherapy or radiotherapy, and history of subfertility with another partner. So again, what is the management of infertility after 1 year? If she is less than 35 years with no risk factor, after 6 months, if her age more than 35 years, or there is risk factor, immediately if there is risk factor, as we mentioned here. So if any of these risk factor, immediately to be referred to Obsingani clinic, infertility clinic. So what we will do first, history. Who should take the history? The history taken by GB or the nurse in fertility clinic or Obsingani doctor. We'll ask about duration of infertility, summary of a previous evaluation and therapy, menstrual history, whether regular or irregular. Because if she has regular history, that means everything is fine. If irregular, we put in mind maybe polycystic ovary or other gynecological issue that needs to do investigation. Sexual history, family history of endometriosis or thyroid issue or family history of infertility, personal and lifestyle history, whether smoking, occupation, exercise, or stress. The same for the male, if any history of sexual transmitted disease, any history of undescended testes, painful scrotal swelling, change in testicular size, chemical or toxinic exposure, prior cancer, chemo or radiation, vasectomy, spinal cord injury, if there is any family history of the same condition, like family history of male infertility or undescended testes or testicular cancer, if there is history of diminished libido, failure of erection, anejaculation, if there is performance anxiety, premature ejaculation. So all this history will be taken by GB Dr. Mill and the female history by the GB female doctor. Also, after history, we'll go physical examination. The first thing, and always I'm asking for body mass index because they found that if the body mass index is less than 17, 17, or more than 27, there is increased risk for infertility. So always advice for optimal weight. Also, if there is any evidence of thyroid abnormality, if there is sign of androgen excess in the form of hyperhirsutism, excess hair, or if there is calictoria, if there is pelvic mass or abdominal tenderness, if there is cervical or vaginal abnormality, uterine enlargement, or lack of mobility, adhesion in case of endometriosis. But the first thing we have to focus by GP doctor or staff nurse is the body mass index. And if the patient is low body mass index, to refer to dietitian for diet advice. And if there is increased weight, also refer to dietitian for weight reduction advice. The same is for the male, because they found that if the male with high body mass index, there's risk of infertility. The same for thyroid, examine liver. There's any gynecomastia, there's testicular atrophy or absence vas deferens, which having in cystic fibrosis, also regarding varicocele. So what are the hormonal that to be done in female? As everyone know that we always advise the women to come day 2 or day 3. We will do FSH, LH, estradiol. These are to be done day 2 or day 3. And you see here the level in the lab, it will come like up to 40, 50, but the normal level for fertility should be 3 to 10. Above 10, there is risk for infertility, that means low ovarian reserve. But still some women will conceive even if the FSH 12. But if reach 15, it is very low rate to conceive. So the normal range is 3 to 10. The LH is the same. Why we'll do FSH and LH? Ratio also in case of polycystic ovary, we'll find the LH is double or triple FSH. Estradiol, the normal is 25 to 75. Progesterone is to be done day 21, but now the study, they omit this test and they are not doing it anymore, because if regular cycle, that means there is a good ovulation. And if irregular cycle, it would be difficult to measure progesterone. That's why they are not doing this test anymore. AMH, we are doing this for any woman above 40 to know ovarian reserve. The level is 1 to 4. TSH, of course, if there is any history of family history or regular cycle, and can be done any day, not necessary to be day 2 or 3 of the cycle. The same for prolactin. And testosterone is preferred to be done in the morning. And DHEAS, DHEA, is better to be done if there is high testosterone, because the testosterone, if it is high, we will proceed with DHEA to rule out adrenal tumor, even though the testosterone might have elevated in case of polycystic ovary. And there's a study that done now prefer to do the prolactin and testosterone in the morning. Okay, the question always asking whether need to be fasting for this hormone or not. So again, as you see here, all the tests not necessary to be fasting, but the TSH is preferred to be fasting and preferred to be in the morning. Prolactin, yes, require fasting and rest, because if the patient is stressed, it might lead to increase the level of prolactin. What about testosterone? They say, yes, testosterone also need to be fasting and in the morning. That's why we always ask the patient for day 2 or day 3 investigation to come, if possible, fasting and in the morning is for TSH, prolactin, and testosterone. Because as you see here, they always prefer morning sample. What about prolactin? If we find prolactin is high, according to the lab, the result, because some lab, they will say that the level is 5 to 25 nanogram per milliliter, but in our lab, it will come like 500 international unit per liter. So if less than 500, it is normal, no action need, but if it comes sometimes 600, 700, always we have to recheck, because sometimes stress, or sometimes lab error, or sometimes if we are doing a breast examination or vaginal examination or vaginal ultrasound, this will increase the level of the prolactin. That's why always we ask the women to come in the morning and fasting. What about 11 to 2000? Always to be repeated, because sometimes there are some error. And if it is confirmed about 1,000, it is better to refer to general medicine in order to do MRI to rule out prolactinoma. And if up to 500, up to 700, no need to treatment. But if 700 to 1,000, so send her to Opsengani, we can start bromocriptine or gabergoline according to which medication is available. And again, regarding TSH, if it is hyperthyroidism to refer to general medicine to start medication. If hypothyroidism, we can refer to Opsengani if in case infertility, because sometimes there's one condition called subclinical hypothyroidism. I mean, for example, TSH, the level is up to 5. If it is come like 5, we will send for peroxidase antibody. And if we find that the peroxidase antibody normal and TSH is high, but T4 is normal, that means subclinical hypothyroidism. In this case, we can manage as Opsengani and we can start thyroxine according to the weight of the patient. But if hyperthyroidism, please refer to general medicine, to not refer to the Opsengani because this is need to be managed by general medicine. What about the seminal analysis? Always, as we say that infertility is either male or female. The question will come and always ask, who is the most responsible for infertility, male or female? Always, and the study found that it's equal. Male infertility is equal to female infertility. So please don't tell the patient women to do investigation and if because the problem in the women. And many women, they are coming, they ask, please, doctor, do for us the investigation because the problem is with us. The male has no problem. No, the studies found that the infertility 50% is due to male, 50% due to female. So in the male, only one test is seminal fluid analysis, and that's all. According, of course, history and examination, and we say the history, you will ask if it has any history of moms, if there is any history of varicocele, any operation, any family history of infertility. And you will examine, of course, also the body mass index, if they take any medication. Some medication will lead also to reduced quality of seminal fluid analysis. So here, if we see that the level of, we will focus on the three important points, we'll focus on the number. It should be more than 39 million per ejaculate, motility more than 40%, and progressive motility is 32, and of course, normal morphology more than 4%. And there are some terms, it's better to use it when we refer the patient. That's, for example, oligospermia. Oligospermia means reduction in the concentration of sperm less than 15. Asthenospermia in the motility less than 32. Teratospermia means in the morphology, if less than 4%. Azoospermia, no sperm at ejaculation. Aspermia, no ejaculation. Negrospermia, only the sperm present in the semen. So if you find, for example, reduction in the concentration, we say oligospermia. In the movement, we will say asthenospermia. In the morphology, teratospermia. And if the reduction in concentration less than, as we say, oligospermia, we repeat it after 3 months. But if less than 5 million oligospermia, in this case, we must evaluate and send second sample immediately, in addition to the FSH, testosterone, and LH. So here, the male infertility will take history, physical examination, and we will see if there is abnormal clinical examination. Of course, you will send to urology or to the surgeon. If it is normal clinical examination, you will send for seminal analysis. If normal, refer to gynecologist. If abnormal means azoospermia repeat in 1 to 2 weeks. If there is pus, refer to dermatology to rule out if there is any sexual transmitted disease, and we can start civitrolzone 500 milligram IM or azithromycin 1 gram. If it's normal sperm, we say refer to gynecology. If abnormal azoospermia, we will do FSH, LH, testosterone, prolactin, and TSH. And according to this level, we will refer to the gynae fertility specialist for exam. So if any problem in male, again, if in examination, refer to the surgeon or urology. But if it is normal clinical examination, we'll do seminal fluid analysis. If it is oligospermia, we'll ask to repeat after 3 months, but if azoospermia, to repeat after 1 to 2 weeks. And mostly azoospermia will do other investigation like FSH, LH, TSH, prolactin, and testosterone. And in this case, we refer to the Hawla hospital, and this can be done by gynecologist or by the doctor, fertility doctor, whoever focal point in that polyclinic. In this case, this male need to be treated by tertiary doctor, and of course, we will refer the women with him, even if all the investigation of the women is normal, because in this case, need XZ or IVF. So again, here, according to the NICE guideline, they recommend that if the first seminal analysis is abnormal, we repeat after 3 months. But FSH, LH, testosterone, and karyotype only if severe oligospermia or azoospermia. That means less than 5 million. Regarding the anti-sperm antibody, they found it is there's no benefit to do it to improve fertility. And here there are some study. Sometimes we need to do counseling for the male and female. This is study what are the good diet to improve and to boost the fertility. They found eggs, whole milk, salmon, broccoli, olive oil, almond, banana, asparagus, ketchup, and avocado. And these are the good picture. You can give it to the patient. Salmon, of course, and almond and banana. These can be given this picture to the couple during counseling, because really this can boost the fertility. In addition, we can also prescribe antioxidant to the male who have mild oligospermia or mild asthenospermia, like vitamin E or oligocare, which is available in the private clinics. And these are the references. Thank you for your listening.